Yes.
We have to start, I think, no?
Yeah, here we are.
Great. Okay, so the next presentation, Professor Svita, do you like to introduce the next presenter?
Yes. Yeah. I'm sorry, I just came back from saying goodbye to the people who were here.
I will present Mrs. Lupi, and you will present all the rest. So the next presenter is Mrs. Lupi. And her presentation is titled CMR Scar and Calculation.
Good afternoon. Thank you for your kind introduction.
Great.
Nice to meet you.
Very welcome.
Thank you for this kind invitation. I would like to share my screen. Okay. Can you see it?
Yes, indeed.
So let's start. And starting from a standard CMR protocol, we can see as a late gadolinium enhancement as a high value for diagnostic accuracy, for clinical management, and as we'll see later, also for its prognostic value. The importance of scar assessment has been recently emphasized in the new cardiomyopathy guidelines, where the most significant innovation is the specific inclusion of tissue characterization using CMR. This reflects the well-known advantages of CMR, particularly its non-invasive nature. Therefore, a systematic approach to diagnosis, starting from the phenotypic presentation of the disease, now have to include the use of contrast-enhanced CMR with a class 1B recommendation. In fact, the history of arrhythmogenic cardiomyopathy already demonstrated the strong agreement between CMR and endomyocardial biopsy findings in detecting myocardial fibrosis, and this led to a revision of the diagnostic criteria to incorporate CMR, which has since gained significant value not only in diagnosis but also in prognosis. Here I show some examples for show the high power of LGE assessment in those patients. And this is to show you the prognostic value of LGE in arrhythmogenic cardiomyopathy. But over time, it has become clear that it is not only the presence of LGE that matters, but also its extent, which plays a key role in risk stratification and also in the prevention of sudden cardiac death. This is particularly well established in hypertrophic cardiomyopathy, where LGE has both prognostic and also predictive value. But in these patients, we know that also edema characterization is crucial, and since its presence, it's associated with more advanced disease and higher arrhythmic burden. Moreover, in differential diagnosis of cardiomyopathies with hypertrophic phenotype, other elements such as mapping techniques may help us in differential diagnosis. And also, we must be aware that in certain conditions, LGE appears in intermediate or late stages of disease. This is especially relevant in amyloidosis, but also in Fabry disease. Nonetheless, available data consistently underscore the prognostic significance of late GAD enhancement in these pathologies. And for these reasons, the new guidelines emphasize that this is not only well known in entities such as dilated cardiomyopathy, but also now in various genetic and acquired disorders that presents with intermediate phenotypes, where the presence of scar becomes essential for disease classification. Let's now let's now look at how to perform LGE assessment. The first step is a qualitative evaluation, which must be confirmed in 2 planes and always compared with corresponding gene sequences, since the primary goal is to distinguish between ischemic versus non-ischemic pattern, with the former typically showing a wavefront pattern from endocardium to epicardium. A widely used quantitative method is the 5 standard deviation technique, in which the software automatically calculates the mean and standard deviation of the signal intensity in the remote myocardium, and then identifies as late gadolinium enhancement those areas exceeding 5 standard deviations from that mean. And this method has shown higher specificity compared to other methods, so is the most used in clinical analysis, in clinical routine. There are also advanced analysis systems available today, often used in electrophysiology for the quantification of fibrosis, starting from CT or MR imaging, aiming to identify also electrically active regions. I would like to show you the workflow for this kind of quantification, gently provided me by Circle. Here we can see how the workflow starts by importing images. AI tools automatically define contours that should be manually adjusted for a more precise evaluation, and then evaluated also on the 3 planes. Here we have a 3D image. After that, there is the possibility to also establish the value. There is also the possibility to establish the scale for evaluated healthy from unhealthy tissue, and then the model is generated with an AI tool, a 3D model with a scale of signal intensity. The scale on the left is set up with data from literature, but it could be adjusted as the operator prefers. And also the software provides data, also numerical data for each layer from endocardial to epicardium. At the end of evaluation, the last point is the possibility to emphasize also the corridors, that are the pathways of electrical tissue, active tissue within pathological areas. And this is the final track. Here you are the numeric data for each layer related to the signal intensity identified from the model. And finally, the last point is the visualization of the pathways. That the software is also useful for atrium. I'll show you just ventricle tool, but it is available also for atrium, and is possible to interact, is able to interact with other softwares used in electrophysiology labs. And that's it. So, going on, Let's now look at how to perform LGE assessment in ischemic cardiomyopathy. Here we need to obtain a multiparametric assessment starting from function and chin evaluation, and also considering the first pass perfusion and also the late announcement sequences that allow us to obtain a comprehensive viability study. So, starting from the first pass, and given the ability of contrast agents to transit in coronary vessels, we can obtain a visualization of first pass perfusion, but when we find an hypoperfusion in first pass sequences, this is due most frequently to fat metaplasia of all the scar or to no reflow. That is a microvascular obstruction that is frequent in STEMI. As a matter of fact, we can distinct fat metaplasia because it is characterized on chin sequences by the well-known India Inc. artifacts, and it is also visible on late gadolinium enhancement, while no reflow is related to small vessel damage, and is visible on LGE sequences. This is an example of a patient with recent STEMI in which also these are China SSFP sequences acquired early post-contrast, so we can see also hyperemic area and the microvascular obstruction within the hyperemic area. In this case, it was very useful also for exemplificative purposes, the mapping. And also this data have, of course, an important role in, again, not only diagnosis, but also in prognosis of this patient. Another aspect to identify is the presence of hemorrhagic infarction that is considered a severe form of microvascular obstruction, and that could be identified by an hypointense ear area and side edema on STIR images 42 star effect of blood. Even in this case, the presence of hemorrhagic infarction is associated to worse prognosis with adverse remodeling, heart rupture, and sudden cardiac death. Going back to the viability evaluation, this is important because we can identify the not only the area of perfusion also within a scar due to microvascular neoangiogenesis, but we can also recognize the area at risk. So that is the area given by the difference between edema area and LGE area. That is the area that could be vitalized. This is another example of acute subacute infarction with an extensive area of hyperemia, and the follow-up of several months later, in which we do not see anymore the hyperemic area. And these are the maps of the same patients, in which we can see the difference in extracellular volume, but also the decrease in T2 mapping values, and so on. Looking at the workflow for the quantification of lead gadolinium enhancement with the 5 standard deviation that we saw before. This is the tool that is called signal intensity tissue. And it, through AI intelligence, provide the automatic contours that could be adjusted manually, and then by setup of the 5 standard deviation reference, we can manually or automatically give the software the start for the identification of the scar. In this case, we can see that sometimes this tool underestimate a little bit the scar. So my recommendation is to try also with the manual check. Looking finally at myocarditis, also in this case, mapping techniques have play a key role, since T2 maps seems to be more sensitive than classical qualitative T2 sequences in identification of edema. And this is well recognized also by the updated Lake-Lewis criteria for myocarditis, in which we have to identify one T2 based criterion and one T1 based criterion in order to reach a diagnosis of myocardial inflammation. There are also supportive criteria and clinical suspicion as well. But with the advent of modern day mapping techniques, we can see how the accuracy of these criteria raise up. Also, even in this case, lead gadolinium enhancement play a prognostic role, and from this evidence, the CMR is recognized also as a parameter of longitudinal surveillance for myocarditis. For the future, are already under development different artificial intelligence model for myocardial segmentation in scar quantification from LGE sequences. These models are very, very long to address, but in particular in this paper, I found a model that outperformed very well compared to the previous models present. So, concluding, I would like to highlight that the importance of scar assessment in diagnosis, disease progression, and risk stratification for all the patients, also in other pathologies, not only in the well-known etiology like hypertrophic or arrhythmogenic cardiomyopathy, but as highlighted in the last guidelines, even in all other situations. And LGE quantification is recommended due to its clinical significance, but also because it allows for a standardization, and in the future it could promote the follow-up in the same patient over time, and also in different patients. Thank you for your attention.
Great. Thank you very much.
Thank you.
From my side as an arrhythmologist, all the times when I am listening the presentations of the MRI specialists, I am not only be happy because you have the opportunity to identify scars and fibrotic areas. But I am a little bit wondering if there is any progress to identify fibrosis in at the atrial tissue.
Yes, and this is a big issue because all the tools available and all our tools are sometimes lacking in sensitivity or specificity. So regarding arrhythmogenic, I have not specific experience with the software used, with the software shown, but I think that a long development is needed in this way.
There are some works coming from the United States, mostly by Marouche, an arrhythmologist and AF specialist. To be honest, everybody is first very happy about these studies. Some even considering that this is too good to be true, how this nice person has managed to identify fibrosis of the atrial tissue. In general, at the moment, all of us working in atrial fibrillation, we have not something very clear if there is any progress.
Yeah, I think if I can add something, I think during an intervention, it might be easier to assess the lesions that you create by ablation because the tissue will be swollen, it will be, there will be edema, and so the wall is thicker, and that makes everything much easier to see whether there is full ablation, isolation of the veins, for example. I think if typically ablation lesions, they have a core of microvascular obstruction inside. So if you have that around the pulmonary veins, I think you could say this is fully isolated, and if there is a gap, you could burn there again. I think for checking with late enhancement the acute effect of pulmonary vein isolation, that could be helpful. In the normal thinned left atrial wall, it is difficult to do that. And personally, for example, here we are much more interested in scar visualization and 3D architecture in the ventricle, because we want to burn, go to ventricular arrhythmias. I think to guide the procedure in the atria, I'm not an electrophysiologist, but I think where to burn, it's given by anatomy. So it is not so important to know the fibrosis before you go for pulmonary vein isolation, because you know by the anatomy where to go. And then maybe it's more useful if you control what you did by late enhancement. I was a little bit surprised or disappointed by the second study of Marouche, where they wanted to show that scar before interventions predicts outcome. But I think this also a little bit complicated by the fact that the treatment is also a variable. The treatment is not always the same. It's not always of the same precision, and different operators are working on these different hearts. So it's a combination of prediction outcome by scar, and then the modulation of this relationship by the treatment itself. So it was a very ambitious study. I was a little bit disappointed that scar before ablation does not predict outcome, but I think there is a confounder, which is the treatment.
Yeah, it's a very, very important topic and very difficult topic. I doubt about the next few years, if we have the opportunity to identify fibrotic atrial tissue. Because, of course, if we had the opportunity to quantify the fibrosis in the atria early enough, in this case, possibly we could develop some pharmaceutical agents to reduce the fibrosis, like all these AMEA, etc. The problem is that, as you said, under the normal conditions, I'm not talking about a swollen atrial tissue. I'm talking about normal conditions. In the normal conditions, in this very thin wall, it's obvious that the MRI has not the ability to identify reliably the size of the fibrosis.
Agree. But even in the ventricle, the quantification is still problematic because there are many different ways for quantitative evaluation, and nobody is reliable enough to use it. The only thing we can do is just to use it for the same patient, the same approach, just to have a guide to follow them up. Otherwise, it's not feasible. All methods have defects, whatever quantitative method you use. And in the atrium, of course, just because it's a thin wall structure, you can't say reliably what is scar and what is not scar. Only in the interatrial area, maybe if it's thick enough, you can say, I see a clear scar, but not in the wall of the atrium.
I think we push a lot the special solution for late enhancement in the ventricles to get a very fine structure with conducting channels inside the scar. So we go to extremely high resolution, at least we push toward that. And I think if we go into this direction, we will, like as a side product, we will also get a better visualization of scar in the atria. We now do the whole ventricle in very thin slices, and then we do a reconstruction, which is not ready to present you today, but I think we will get very high resolution in the myocardium. And if this works, we could just extend the volume that we cover. We would pay with machine time, but we would get scar visualization in a quite robust, reliable way in the atria. But for the moment, we push really for visualization of scars and quantification in 3D of scars in the ventricle. But once this works, it will also work in the atria.
But anyway, we have to comment here that as everybody has recognized, everything is now, let's say, left upon the atrial, left upon the artificial intelligence coming era. So who knows? After some years, these superhuman capabilities of the artificial intelligence in visualization and special diagnostic. Possibly, I'm serious now, possibly, especially the intracardiac MRI could, combined with artificial intelligence, could offer us some diagnostics, some advanced diagnostics. Who knows?
So keep waiting.
Yeah.
In any case,
I think we could discuss that for hours, or we could a meeting construct on that. But I think I'm a big fan of AI because I was very skeptical at the beginning. Then it starts to work now. I think it's great, but there is a big risk with that. And I think we must be very careful not to underestimate the risk, because if you can clean up images with AI, they look beautiful, but you don't know what is cleaned up. He can also clean up, and you get rid of much more of late enhancement than you want to get rid of. You can take out gray zones, which might be even more important than the complete bright zones. So I think I would wish that in the future we would very, very rigorously test AI and not just implement them because the images look nice. Because
please, Professor Sweeter, don't underestimate, but talking about AI and especially talking about LLMs, we're talking about a 3 years baby. 3 years baby. Please, wait a little bit. Wait a little bit to be an adult.
Yeah, but you know, if this little baby is adult, we will be kids. Then we are the babies. Then they will tell us what we have to do. They will take decisions on whether to implement that ICD, etc. Now we can now educate our baby, which is called AI. If we miss this phase, we will be the babies. And because somebody said it will be a very difficult thing if people with our intelligence, we want to control artificial intelligence, which will be much more intelligent than we are. So if the new intelligence is more intelligent than we are, we cannot control anymore.
So I will send to you.
But we have to use the time.
I will send to you on your email a video, which is a montage from different videos that I prepared for a special case. And if you find the time, it's 30 minutes. If you find the time, go through and you recognize the realities. Indeed, in this video, most 5 high protagonists, most of those Nobel Prize winners are talking about. But all of those are very positive around the consequences of AI in medicine and healthcare. On contrary, all of those are very skeptical, very, very skeptical about the consequences of AI in general on the human being. There are 2 different things. Anyway, let's move.
Let's move to the next.
You have the link. Do you have the link of that video?
Okay.
I have your email, but please send me your email of all of you, and I will send to you in a couple of hours this video. You will be very happy. Trust me.
Yeah, I will look it. Yeah.
About the quality of the video, I'm not sure about the quality of the news coming. Okay.
Okay.
Great.
Okay.
Go ahead, please, with the next speakers.
Thank you.